I have cared for many vulnerable migrant women over recent years, and some of them I can help, and sadly, many others come too late or have barely adequate maternity care. I'm going to talk about two cases. Obviously, the names have been changed. By the time that Eve presented, for example, to the emergency department a few years ago with severe abdominal pain, vaginal bleeding, she had severe high blood pressure with renal impairment. A short time after her arrival, Eve gave birth to her stillborn little girl, who she called Grace. And I certainly remember that day, and I don't think anyone in the department that day, from porter to doctor, was left untouched by Eve's anguished cries as she cradled her dead daughter. Now, chatting to Eve after that event, she thought she had been 7 months or so into her pregnancy, but using her words, being without papers, when the pain started a few days prior to her arrival at ED, she had sought advice from an auntie in the community rather than a midwife or doctor. She had been afraid to come to hospital. She had no money to pay for her care. She didn't have the right papers. She was deeply worried that the hospital would report her to the authorities and that she would be detained and deported. So she had two major concerns. I'm really privileged to work with Maternity Action, the RCOG, in this particular area of work. I mean, a fear of charging and fear of being reported are two of the biggest barriers to safe maternity care for this cohort of women. And we're launching this short guideline to help you work with those women who may be affected by charging, to work with your midwives, your local overseas visitors teams, and I'll outline how I do that in Oxford shortly, and also bringing into that MDT working your safeguarding teams as well. And I think the key take-home message here is that we can't afford to delegate this responsibility if we're truly committed to addressing health inequalities in maternity. Women such as Eve are amongst some of the most vulnerable women we care for and at greatest risk of poor outcomes in pregnancy. Many of the women that are potentially chargeable have fled to this country to escape war, honour-based violence, forced marriage, FGM, and other forms of gender-based violence. And many will lack the knowledge or wherewithal to know how to register what might be a reasonable asylum claim. Others, sadly, have been trafficked. Some have overstayed visas. Some have fled domestic violence and no longer have the right to remain under a spousal visa. And these women are part of the population that you will be working with in the UK, wherever you're based. And importantly, contrary to what, the Daily Mail and other papers or those who support the hostile environment might portray, these women are not health tourists, they're desperate. And accessing care during pregnancy will help keep them and their babies safer, and that's a well-established fact. It also helps them access care with other things, help with other things that they may be in need of. In Oxfordshire, our emerging group of undocumented women are from the East Timorese community. And now, as a former Portuguese colony, many initially came to the UK through the EU migrant route and legally settled in the UK. But those who have come afterwards in this sort of brave new world of post-Brexit may have fallen foul of the complex rules around settlement, and lacking settled status then become undocumented. And with our East Timorese community, very few speak English. The majority work in low-paid jobs and experience conditions of poverty and destitution. And for us in Oxford, they represent some of the most vulnerable women in our care. So it's important that wherever you work, that you do have an understanding of the communities of women that you look after and where their particular vulnerabilities may be in relation to charging. And I agree absolutely 100% with the college stance on this, and with Maternity Action stance, that is morally reprehensible at a time when we're being instructed to tackle maternity health inequalities, that we continue to charge those most at risk of harm. And I think it's important to understand that our overseas visitors teams are not sort of ogres in management. They are legally obliged to seek out those who are chargeable and to produce the invoice and to chase the debt. But they don't possess the skills that you have in relation to being able to ask questions around potential exemptions, and to make inquiries around potential destitution. It's outside their scope of work, and that's where we come into the play, in that we can actually help them understand that and support them better in the work that they're doing. So how can we use this guide in practice? So I'm going to give you an example of a recent case which has led to the sort of us in the trust developing a way of working together with our overseas visitors team. So Naomi, in this case, was unbooked until she presented to the maternity assessment unit at 20 weeks with vaginal bleeding. Now, she was on a visitor's visa to the UK to visit her British husband. During that first admission, she disclosed a previous history of term stillbirth and was therefore transferred to high-risk pregnancy care pathway. She went on to have recurrent vaginal bleeding and abdominal pain and several more hospital admissions. And her team were surprised, as you can imagine, when Naomi asked for a fit note to fly back home. And she was citing that the reason why she wanted to do that was to be with her extended family. Now, aware of the poor health infrastructure in her country of origin, her obstetrician explained the concerns regarding the risk of abruption and the risk of stillbirth, and also deemed that with recurrent pain and bleeding, that she was unfit to fly. Now, Naomi remained living locally, but she defaulted from antenatal care. She did not return her midwife's calls. And at 32 weeks, her midwife doorstepped her to sort of inquire why she was defaulting from care. And Naomi then explained that she wanted us to stop giving all maternity care to her, all pregnancy care, because she couldn't afford the bill that she had received. And her belief was the bill had come from us in maternity. She also disclosed that she had no means to pay for the bill, and that her husband was in significant debt, and that the stress of that debt was putting a lot of strain on the marriage, with sort of an allusion to some potential domestic violence as well. So she asked if it was possible just to come to hospital to have her baby. Now, knowing of the interest that I have in NHS charging and the clinic service that I run through the Rose Clinic, the team discussed Naomi with me. And in the first instance, I spoke with the overseas team to determine what had actually been presented to Naomi. And cognizant that maternity care is deemed as immediately necessary, the overseas team had not actually asked for any money up front, as is the practice and the guidelines, but simply had informed Naomi that she'd be liable for charging as she was on a visitor's visa. And an estimate of the cost of her care was given, with the option of paying if she wished in installments after the baby was born, but with the option to start any payments that she wished or was able to make during pregnancy. Now, when I explained the background situation to our overseas team, that we, in essence, had removed her ability to return to her home country because we hadn't deemed her fit to fly, but also presenting the real human side to this story, that this is a woman who had experienced the tragedy of a previous term stillbirth, and also given her high risk picture in this pregnancy, that we were deeply fearful that she would experience an outcome quite similar to Eve in relation to stillbirth. They agreed to pause all further communications with Naomi. When I was explaining the challenges around her husband's debt, they also were willing to consider that we could explore potential exemptions, but also explore whether she was manifestly destitute and therefore unable to pay. Now, we shared that information with the couple. They agreed for a referral to a local charity in relation to their debt in order to document their debt, but also help them with debt management. And her husband consented to full disclosure of his debt and financial situation to the overseas visitors team. Now, with agreement from the trust, the overseas visitor team themselves cannot just cancel debt, but working with the finance team, it was recognised that Naomi would be unable to pay for care, that her fear of care was jeopardising her well-being and also the well-being of her child. And that although the record of debt would remain on her file, the trust used their own discretion to write off that debt. And Naomi went on to have a healthy baby girl 4 weeks after this. So we as a team felt that this was a near miss. We were very mindful of what had happened previously with Eve. But had we not had the knowledge or advocated for Naomi, the outcome might have been very similar to Eve. And following on from that case, we in the trust decided to formalize that arrangement between the overseas team and maternity with monthly meetings for about 30 minutes each month. And sometimes meetings don't even last 30 minutes. So the overseas team can discuss who's flagging on their system. So the Home Office can flag women with sort of dubious immigration status, or those who are known to be undocumented and potentially liable for charging. And this enables us to be proactive in supporting the women's maternity team to explore exemptions, but also the financial situation as well. It also helps, and this is what the overseas teams say, it helps them understand the population locally. It helps them understand the person behind the hospital number and the invoice number. And it enables bi-directional learning too, because I now have a great understanding of their challenges as well. We've also worked towards improving their knowledge about what those exemptions are and the inquiries we have to make, and agreed a way of recording those into the maternity records such that the overseas team can access that when someone flags on their system and determine whether that would represent an exemption as well. So I'm just conscious of time and I don't want to eat into the vital sort of video and also the discussion, but what would be the take-home messages if I were to give some today? It's please don't put this notion of NHS charging and our responsibilities onto that sort of too difficult to deal with pile. Please read the guideline, understand the importance of your role and your advocacy. And I would say that being a consultant obstetrician, you do carry some clout, as it were, with trust management as well. We were able to advocate and we should be using our voice and our platform. I'd also ask that you're professionally curious. Get to know your local communities, get to know where the vulnerabilities are. When you see incidents coming through in relation to unbooked women presenting in labour, unplanned home births, ask the question, was that happening out of fear of or actual charging? Was that a consideration? And with those women who have frequent non-attendance, substitute DNA with CNA, could not attend, or even TA, too afraid to attend. And above all, keep the woman at the heart of the discussion, remembering that exploring those exemptions and exploring whether there is destitution, you're not only going to help in relation to NHS charging, but you could help her access sort of the help that she needs beyond just NHS charging.